Thank you everybody for being here today. I am Dr. Lauren Nye, and I'm going to be moderating case 3, where we're discussing a case of ductal carcinoma in situ, DCIS or early stage breast cancer. I am an assistant professor of internal medicine at the KU Cancer Center and a breast medical oncologist. And I have an amazing team of women with me here today as our panel of experts. First up is Dr. Amin. She's an assistant professor of surgery at the KU Cancer Center and a breast surgical oncologist. I have Dr. Onalisa Winblad. She's a breast radiologist at the KU Cancer Center and director of breast imaging. And I have Dr. Shalina Gupta-Burt, an assistant professor of radiation oncology and radiation oncologist at our KU St. Francis campus in Topeka, Kansas. So to get started with our case, we have a 40-year-old woman who presents for her first screening mammogram. And the findings showed a 1 centimeter area of calcifications in the upper inner quadrant of her right breast. She has no significant past medical history, no significant medications. She has 2 children with her first live birth at age 25, and she did breastfeed. She's not having regular periods because she has a Mirena IUD in place. And her family history is significant for a maternal grandmother with breast cancer diagnosed at age 60. So Dr. Winblad, can you walk us through these images?
So these are the 2 screening mammogram views of our patient's right breast. And I have a pink circle around these subtle calcifications that we identified in the inner right breast on one of her screening mammogram views. So therefore, we called this patient back, gave her a BI-RADS Category 0 assessment. So to obtain additional imaging, which is required when we have an abnormal finding. BI-RADS is our standardized method for describing findings and giving recommendations to our providers. And BI-RADS 0 is appropriate for this patient since we need additional imaging. And these are the 2 spot magnification views of our diagnostic mammogram for this patient. I have pink circles around the small 1 centimeter group of calcifications in her right breast. On the next slide, I have a photo magnified view of these calcifications. They're subtle enough that it's difficult to see them without the magnification tools. And in breast imaging, we would describe these calcifications as amorphous in their morphology. And that simply means that they don't have a distinct shape. And the morphology and distribution of calcifications really is important for understanding the risk and likelihood of malignancy. For our particular patient that had an amorphous group of calcifications, the positive predictive value of malignancy is about 20%. So now for this patient, we're going to give her a BI-RADS Category 4 assessment. BI-RADS 4 means that our finding is suspicious and has anywhere from a 2 to 95% chance of malignancy. And as I said, our patient has around about a 20% likelihood of malignancy, so this makes sense. All suspicious findings in breast imaging require tissue sampling. And so for our patient, we're going to recommend a stereotactic biopsy of these calcifications to get a tissue diagnosis.
So she went through and she had her stereotactic biopsy of the area of calcifications, and the pathology describes fibrocystic change. And so Dr. Winblad, can we start by first discussing why did we go with a core needle biopsy for her?
So for this patient, in contemporary practice, core needle biopsy guided by imaging has largely replaced surgical excision. Core needle biopsy is almost always sufficient for making a diagnosis. And in breast imaging, we have several tools to ensure that we have concordance of our sampling with core needle biopsy, including things such as specimen radiographs, placing tissue markers at the site of our biopsy, and doing post-procedure mammograms.
So I would say we frequently see patients coming in after they've had an excisional biopsy. Is there a reason that you would select a core needle biopsy over an excisional biopsy for this woman?
So the Agency for Healthcare Research and Quality commissioned this systematic review published in the Annals of Internal Medicine in 2010, which actually looked at the effectiveness of core needle biopsy as compared to open surgical biopsy for diagnosis of breast lesions. And while surgical excision is highly accurate, core needle biopsy saw fewer complications and shorter recovery time. Core needle biopsy is very accurate. And very importantly, it also allows women who end up with a cancer diagnosis to be managed with a single surgical procedure, and also allows for consideration of neoadjuvant systemic therapy.
And so our patient had fibrocystic change on that biopsy. What would you recommend is the next step for her?
So for this patient, we had a post-procedure mammogram and tissue radiograph sample that didn't have a lot of calcifications. Her tissue marker clip was a little bit off. And so for this patient, when we did our assessment for concordance after the biopsy, we felt like she might need some additional follow-up. And in her case, we felt like we could do an additional stereotactic biopsy to get a better sample that would contain more calcification and allow for a better diagnosis for her.
So tell me more about what that concordance conference is, because I don't know if that's standard practice for everybody listening to have this type of conference available to them.
So all breast procedures undergo concordance for sampling, and that's to ensure that we feel that the imaging is concordant with the pathology findings. And it's even better if you can have a multidisciplinary assessment of concordance. At KU, we have our pathologists, our radiologists, our oncologists, our high-risk providers all together in one room, evaluating these patients' cases to determine if our imaging findings and pathology findings make sense, and determine whether or not the patient may need additional follow-up, such as additional biopsies, follow-up imaging, or maybe even high-risk follow-up.
Thank you. So our patient does undergo that second stereotactic biopsy, and the specimen radiograph demonstrated an abundance of calcifications, and this time the pathology describes atypical ductal hyperplasia. So Dr. Amin, I'm going to send this over to you to describe what is atypical ductal hyperplasia.
Yeah, thanks. So this is a pictorial representation of the progression of what a normal duct goes through as it would go on to form an invasive cancer. And ADH, or atypical ductal hyperplasia, is epithelial proliferation that forms in the terminal duct lobular unit. It's similar to DCIS, which is the next step beyond, in that they both have cytologic atypia and architectural change, but the atypia are quantitatively and qualitatively insufficient in ADH to diagnose DCIS. So it's typically differentiated from DCIS in the sense that the atypia only involves 1 or 2 ducts, and it typically measures less than 2 millimeters. So ADH is fairly common. It's identified in 8 to 17% of all percutaneous biopsies that our breast imagers perform. And there's a concern when we have this diagnosis that there could be a sampling error, because the core needle biopsy often is not removing the entire lesion. And so there can be what we call an upgrade when the patient would go on to surgical excision, where we would go on to identify either a DCIS or an invasive cancer. And the contemporary literature quotes a rate of approximately 10 to 40%. ADH is also something that we call a non-obligate precursor to breast cancer. And so women who have atypia are also at risk bilaterally of developing a future breast cancer higher than the general population.
And that upgrade rate of 10 to 40% can sound terrifying to some. And I know we're going to talk about it more in a couple of slides, but just acknowledging that is quite a broad range for many women to hear.
Yes. So this is the latest NCCN criteria for women who have core needle biopsy diagnosis of atypical ductal hyperplasia. The recommendation is for surgical excision because of that high risk of upgrade.
And so tell us a little bit about how we manage this at the KU Cancer Center.
So routine surgical excision for ADH is overtreatment for the majority. Ideally, a woman would be offered surgical excision if they're found to be at high risk for upgrade, and all other women who are at lower risk could be offered surveillance and consideration for chemoprevention, and only have intervention if there's a change over time. So multiple studies have been performed to try and define this favorable group who are lowest risk for upgrade. And this is our own institutional data. that was defining our lowest risk of upgrade group. This is a study that was performed over the course of time from 2006 to 2015 of 124 patients. Our overall upgrade rate at our institution is 17.7%. And we identified our patients with the lowest risk of upgrade would have small lesions, less than 1 centimeter, have good sampling of the target lesion where 50% or greater is removed by the biopsy, have a low burden of atypia with only 1 to 2 foci, and that the atypia would not be associated with individual cell necrosis. We identified that patients meeting all of these criteria, none of them will go on to upgrade at the time of surgery. And so based on these findings, after rigorous multidisciplinary review at our conference, women who meet these criteria are offered observation and counseling with chemoprevention in our high-risk breast cancer prevention clinic over surgical excision. And so what you're seeing here is our follow-up work looking at how the oncologic safety of offering these women observation over excision. So in that middle column, the criteria, the meeting low criteria are those which were just defined previously. About 19% of our cohort since determining these criteria meet this low risk criteria. And many of those women have stereotactic biopsy over other modalities. They obviously all had their target removed. A few of these women still went on to surgical excision, but none of those women that met the low risk criteria upgraded to malignancy, again, confirming our findings that we have identified that low risk group. Those other patients who were recommended for excision, 26% of those women upgraded to malignancy, so clearly at higher risk for underlying disease. And the key here is that those women who met low risk criteria who do not have excision of their ADH, only 2 of them required additional biopsies over follow-up, none of which were at the site of the previous ADH. So this really quells the concern about a missed breast cancer diagnosis during follow-up.
So our patient was discussed, as we said, at the Benign and High-Risk Breast Concordance Conference, and her breast imaging showed post-biopsy mammogram with greater than 75% of the calcifications, which were the target, were removed by the biopsy. The pathology showed 2 foci of atypical ductal hyperplasia was present, and it was associated with the calcifications, and there was no individual cell necrosis seen. And the recommendations were for referral to the high-risk breast cancer prevention clinic for active surveillance. So Dr. Amin, let's talk a little bit more about the ADH pathway that we have.
Yes, so all of our patients are reviewed at this Benign Concordance Conference, but we've really tried to be quite clear in our definitions of who we think would benefit from excision because of their higher risk of upgrade and who would potentially benefit from being offered active surveillance. And so our patient is in the best risk category. She had screen detected calcifications, and it was a small target that was well sampled with low burden of disease, which is exactly our definition of that low risk category. And so she was appropriately recommended for active surveillance. She'll have a follow-up mammogram in 6 months, and her risk of upgrade should be essentially 0% on this.
Thank you. And so she did come to the high-risk clinic for evaluation, and there we talk about risk estimates based on just having a biopsy with atypical ductal hyperplasia present, which is again a broad range based on many factors that's estimated between a 20 to 40% lifetime risk of developing breast cancer, which is not very helpful to women when you give them such a big range. We also look at the Tyrer-Cuzick, which is our family history-based model. That's the image that you see on the left of the screen. And when we put ADH or atypical hyperplasia into that calculator, unfortunately, we're almost always going to get a lifetime risk of about 40%. That's just how the model is programmed. But as we can see here, it estimated her lifetime risk was about 42.8%. She underwent screening imaging, or what was recommended was screening imaging, with a clinical breast exam every 6 to 12 months, an annual screening mammogram, preferably the digital breast tomosynthesis or a 3D mammogram, and an annual breast MRI can be considered based on our high-risk screening guidelines. We discussed the risk and benefits of breast MRI, which we've talked about in a different presentation during this conference. And then we also talked about risk reduction measures that we can take, focused on both lifestyle modifications as well as chemoprevention. So chemoprevention is a medication or a drug that can be used to lower the risk of breast cancer. It does not involve chemotherapy and it does not fully prevent breast cancer, but it significantly lowers the risk. It is recommended to women with a 5-year risk over 1.7%, women who have greater than 10 years life expectancy, and typically we wait till a woman is at least 35-year-old and has completed childbearing. For a premenopausal woman, our only option right now is tamoxifen, despite decades of research. And for postmenopausal women, we can choose from tamoxifen, raloxifene, which is a selective estrogen receptor modulator, or a SERM, similar to tamoxifen, or an aromatase inhibitor. We choose which agent depending on the preferred side effect profile. They all are anti-estrogens and can all cause some vasomotor symptoms, but they all have more unique, higher risk side effects that some women would be more concerned about. Overall, though, none of these agents provide a survival benefit, which can be difficult for women to accept the side effects with no known survival benefit. There's been many large trials looking at the chemoprevention agents, which I've listed here, and all of them show a similar risk reduction of approximately somewhere between 50 and 60%, depending on the risk that we're starting with, of reducing the risk of breast cancer, but yet no survival benefit. The challenges with chemoprevention have been shown to be low uptake, so less than 40% of women, even who are diagnosed with ductal carcinoma in situ, will be agreeable to take a chemoprevention agent, and this is mostly due to side effects and that there's no survival benefit. There's also a lot of challenge with provider comfort with prescribing these medications. Rarely do these women make it to a high-risk oncologist, and so we're really relying a lot on our primary care providers to prescribe drugs that they're not comfortable with. And so there is some work in the literature focusing on education on chemoprevention or identification on how to get women to a provider that can prescribe chemoprevention. We have had some excitement in the field, though, lately with low-dose tamoxifen. So this is the same drug we talked about before that can cause side effects, but at a quarter of the dose, so 5 milligrams a day instead of 20 milligrams a day. And this was a study looking at low-dose tamoxifen versus placebo in women with things like ADH or DCIS, a wide range of ages in this study, including pre- and postmenopausal women. And we saw risk reduction similar to what we saw with this full dose of 20 milligrams per day of a hazard ratio of 0.48. I will tell you that in 2019, when the data was updated at the San Antonio Breast Cancer Symposium, there was some concern that in premenopausal women, the hazard ratio was only 0.7, possibly because they have more estrogen on board, but there was more workup being done at that time. However, what we did see was that women reported similar hot flashes, whether they were in the placebo group or the tamoxifen group, as well as similar adherence, promoting the idea that this is a much more well-tolerated dose of tamoxifen for women. We also did not see any increase in any of the serious adverse events, such as CVT or additional neoplasms, such as endometrial cancer. Our patient declines chemoprevention. She declines the MRI screening due to concern of increased false positives or need for future biopsies, and she follows in the high-risk clinic with annual mammography. 2 years later, her mammogram shows a new focus of calcifications in the contralateral breast, again measuring about 1 centimeter. And so, Dr. Winblad, do you want to walk us through these images?
So this patient's most recent screening mammogram now demonstrates a group of calcifications in her lower outer left breast. As Dr. Nice said, these measured about 1 centimeter. This small group of calcifications is pleomorphic, which is abnormal shapes and sizes, and that is a BI-RADS category 4, also very suspicious. So We therefore recommended that she have an additional stereotactic biopsy, this time of the left breast, to get a tissue sample and determine what these calcifications are.
And so, Dr. Amin, it showed ductal carcinoma in situ this time. Do you want to tell us about that?
Yes. So this, again, has kicked up the spectrum just a little bit, where there's more cytologic atypia and so this is staged as stage 0. It's staged as a breast cancer. But because it's non-invasive, it cannot by definition spread to lymph nodes or spread anywhere else in the body. And so I tell my patients, your survival is essentially 100%.
And so how do we treat DCIS?
Yeah, so despite this, DCIS is usually treated like an invasive cancer in the sense that we need to consider treatment of the breast and treatment of the whole body. And so for treatment of the breast, this area is usually removed, either with a mastectomy, which is removal of the whole breast, or just removal of the area of the biopsy, which is called a lumpectomy, and this is typically followed by whole breast radiation. A medical oncologist could then consider endocrine therapy for hormone-positive DCIS like our patient has, but chemotherapy or HER2-directed therapy would never be indicated for non-invasive cancer.
And again, these anti-hormone therapies are still considered chemoprevention, even when we're talking about stage 0 breast cancer, to help prevent essentially a new breast cancer from developing. The risk of finding disease elsewhere in the future, like Dr. Amin said, is incredibly low. There's been reports of that, but it's well under 2% risk. So what is this?
So we do have a national accruing trial, a clinical trial that is bringing in the question of, do we really need to be so aggressive about our management in this non-invasive cancer? And our gynecologic and urologic colleagues have actually been ahead of us for years in management of cervical cancer and prostate cancer, in the sense that when they identified non-invasive disease, those patients are often recommended for watchful waiting and additional biopsies for progression. And surgical intervention is reserved for those with invasive disease. And so this trial is something that we have open here at our institution, and it's called COMET, which is a comparison of operation to monitoring with or without endocrine therapy for low-risk DCIS. And so these patients are randomized. This is a randomized trial, 1-to-1. Half of them will be randomized to the first arm, which is GCC, which is an abbreviation for guideline concordant care, or essentially surgery in some form or fashion, and it's the patient's choice. They do not have to receive radiation after lumpectomy, but they should certainly have that conversation with radiation oncology. They do not have to take endocrine therapy, but they should have those conversations. And then they're followed as we would typically follow patients, where they typically have annual mammography on mammograms on an annual basis over the course of 5 years, as long as they have breast tissue. The other arm is the AS, or active surveillance arm, and those patients do not have surgery, do not have radiation. They do not have to take endocrine therapy if they are in the observation arm, but it certainly is offered them. And we follow them a little bit more closely with imaging, with mammograms every 6 months. And if we determine that they are having progression, that is typically biopsied and then converted to surgery if we identify that they have progressed to invasive disease. We also acknowledge that there's going to be some women who, after their randomization, may decline their randomization. And so we still want to collect their information as well. And that's the last group there, where they can essentially select which arm they want to be in, and we will follow them and observe their outcomes. So there are advantages and disadvantages to either arm. In surgery, obviously the area is removed, so that will reduce the chance that this would then go on to progress to an invasive cancer at that site. But the surgery results in loss of some or all of the breast, which may change the look and feel of the breast. Whereas with active monitoring, you're avoiding those side effects associated with surgery and/or radiation, but patients may experience increased anxiety with concern that the DCIS may progress. They certainly require more frequent monitoring and imaging. They may require additional biopsies because of this. and they may require surgery and radiation that could be more extensive later on if they go on to develop an invasive cancer.
So our patient was interested and consented to the COMET trial. She was randomized to the surgery arm, and she accepted her randomization and proceeded with radioactive seed localized lumpectomy. The final surgical pathology demonstrated a 0.6 centimeter grade 1 hormone positive DCIS, and the closest margin is the medial margin at 2 millimeters. And so Dr. Amin, can you talk a little bit about what does that margin mean in DCIS?
Yeah, this is our society consensus from the Society of Surgical Oncology and the American Society of Radiation Oncology. We determined that a 2 millimeter margin will minimize the risk of an in-breast tumor recurrence, and that more widely negative margins do not defer a bigger benefit to this. And if your margins are more narrow than the 2 millimeters, that this is not an indication to proceed with mastectomy.
All right, now I'm going to bring in Dr. Gupta-Burt to wrap us up. We have 5 more minutes to go, and we're going to talk about the role of radiation for DCIS.
Thank you, Lauren. So the role of radiation in patients who have had a lumpectomy and have achieved negative margins has been pretty well established with regard to having a decrease in the local recurrence within that breast. Now, having said that, as you've been seeing throughout this presentation, there is a spectrum for patients with ductal carcinoma in situ in terms of their aggressiveness or their behavior. And the question has always arisen, do all patients who have undergone a lumpectomy with DCIS need to have radiation? And so if we go to the next slide, a couple of trials have approached this subject. So the ECOG 5194 was developed specifically to select out certain patients that we could do a lumpectomy alone without the need to do radiation. And so they looked at what we would refer to as good risk patients. Who would those patients be? Patients with small tumors, patients that did not have any negative pathologic features such as necrosis within that sample, typically tumors that are ER/PR positive. And they defined these patients as low risk and decided just to do lumpectomy and follow these patients. And what you're looking at here are 2 separate groups. The cohort 1, which is in the yellow, are the patients that had more aggressive lesions. So those are patients that had chemonecrosis or had features on the pathology report or size that was more worrisome. In fact, those patients with the high risk features pathologically were even defined as smaller at 1 centimeter. And you see over time on that graph that the likelihood of recurrence becomes higher. That's that blue line that you're seeing, the higher risk patients. And at 10 to 12 years, the risk without radiation for these patients is around 20% of having cancer come back. Now, in those highly selected patients that have the good risk features, which is the yellow line, at 10 to 12 years, we still saw a recurrence around 10 to 12%. Now, one of the problems with this trial is none of the patients were randomized to getting radiation. And you wonder, could that 10% have been decreased with the use of radiation? So the RTOG on the next slide developed this trial, the RTOG 9804, which randomized the highly selected group of patients that we defined as a low risk DCIS, smaller tumors, less than 2.5 centimeters, all of which had negative margins, at least 3 millimeters, and they were randomized to either getting radiation or not. And overall, a couple of things to really pay attention to. So if you look at the dotted line, those are patients that did not get radiation. Overall, they did pretty well. They actually had a relatively low rate of recurrence. But the interesting part is if you look at the group that got radiation, they benefited. It was markedly decreased even at the length of follow-up, median follow-up at 7 years. They only had about a 1% likelihood of local recurrence. And so the takeaway from this is even the good patients with good features with their DCIS may benefit from radiation. So traditionally now, we still offer radiation to patients after a lumpectomy with negative margins, even with good pathologic features.
Do you want to tell us a little bit about the genomic assay for DCIS, or should we go on to talk about the different techniques for radiation?
I think the question of genomic assays is a great question, because I think we still need to address the variation with regard to the spectrum of DCIS. You know, what's really driving each of these tumors. And if you look at the DCIS score, and I'm so sorry, you guys, I can't see the slides anymore, but if you look at the DCIS score, what you're basically seeing is you can look at an individual tumor and look at a profile of the genes that are expressed in that particular tumor and look to see if you can predict which patients are going to have a higher likelihood of recurrence. So this assay is available and it's valuable in terms of an individual patient to assess the aggressiveness of the behavior of her DCIS. But nonetheless, even if you have a low risk DCIS, the benefit of radiation has been established. So even the low risk patients can get benefit from radiation. But I think it's valuable to have this DCIS score just to give each individual woman an idea of what is driving her DCIS. One of the most interesting features of this particular score is it does give us an idea of tumors that may end up having a higher likelihood of invasive recurrence, and those patients may end up opting to have radiation instead of being observed. Having said that, the cost of these assays are quite high. And so in this day and age, it hasn't become standard to usually use these assays, but as they develop and more assays come on the market, for example, the Decision assay is another one that's also available. We may be seeing more use for these assays to be able to determine which women may benefit or not benefit from the addition of radiation. Now, with regard,
sorry, I think we're kind of running out of time, and so I was going to wrap up the story here for everybody. Our patient proceeds with radiation. She was young, like you said, and even though low grade would likely benefit. And we'll say you treated her with 15 fractions to the whole breast to a dose of, oh gosh, I'm going to say this wrong, 4,005 centigrade, followed by a boost to the lumpectomy cavity. Right. And after completion of radiation, she met with a medical oncologist to revisit the need for endocrine therapy, again, the chemoprevention. And then we did have some recommendations for surveillance imaging for her. So what's the recommended surveillance, Dr. Winblad?
The recommended surveillance for women after breast conservation therapy is a diagnostic mammogram approximately 6 months after breast cancer treatment is finalized, and then annual screening mammogram thereafter. The American College of Radiology does recommend annual surveillance with breast MRI for women who have a personal history of breast cancer and dense breast tissue, or those diagnosed before age 50. So our patient does fit within that recommendation and can undergo supplemental breast MRI screening if she desires.
All right, well, I think we are out of time, but thank you so much to our awesome panel and to our audience today. I hope you've been engaged in the chat. And we have 2 great non-CME presentations coming up next during the break. And if you attend one of these, you'll receive a gift card. So I hope you enjoy the rest of your day.